Definitely. If there are any questions, I can take. I mean, if you have any practical problems during the practice that you must have done in last few months, or I can share my presentation, which I have already, I mean, posted the video on YouTube regarding setting up a myopia clinic.
हेलो।
Yes, Nathan.
जीतू भाई, ये is peripheral refraction needed in every patient?
No, peripheral refraction. See, typically, if we go by the theory of Earl Smith, it is definitely mandatory that peripheral refraction should be hyperopic for axial elongation. Now, the problem is that when you talk about peripheral refraction, there are publications in which they have said that in Indian population, not only there have been nasal temporal asymmetries, which means the temporal area of the eye has peripheral hyperopic refraction, and nasal part has peripheral myopic, or there is no difference between the center and the periphery. Whereas this was from, I think this was from LVP, Dr. Pawan Varkicharla and his friends, or rather his colleagues, had published this. And then I think there was a small study done from Narayan Netralaya by Dr. Jyoti Matalia, Sumita Muthu, on almost 25 to 30% being, peripheral. There is no peripheral hyperopia in those patients. Uh, Now the point is whether glasses will work in those patients or they will not work, and whether the uh, 70% claim that those glasses make is whether it is only for those patients who have peripheral hyperopia. I don't think whatever work we have done, we have found out that whether even in children where peripheral hyperopic refraction is not there, glasses are still working. That is number one. Number two is that, I don't remember whether in this group we had talked about the sweet spot or not. So the problem is that, there are few studies where they have not been able to find out that how much peripheral refraction is important. My point is that uh, whether it is 10-degree peripheral refraction which should be hyperopic, or 20-degree peripheral refraction which should be hyperopic, or 30-degree peripheral refraction which should be hyperopic. So the more peripheral you go, more are the chances that there will be hyperopic refraction, because curvature of the eyeball will get curved in the periphery, not in the center. Obviously, in the center part, if it is curved, then you are actually looking at a posterior staphyloma rather than a childhood myopia. But
Yes.
the another important point which we should try to understand in this is that, whenever we think about peripheral hyperopic refraction, we only think about the anatomical layout of the posterior part of the globe. We don't think about the peripheral corneal refraction, because at the end of the day we are talking about refraction and not talking about the anatomical curvature of the eyeball in the posterior part. So when you see the cornea in the periphery, if you see, to compensate for that peripheral curvature of the anatomical curvature of the eyeball, if you see, the peripheral cornea also flattens out and becomes more and more hyperopic. And that is also probably one of the major reasons why peripheral hyperopia is not more than 1 or 1.25 diopters. Normally, if you measure peripheral hyperopia with the peripheral refraction aid, even at 20 degrees, you will not see a huge difference of 2 or 3 diopters. Whereas if you think about the curvature of the eyeball, and if you think that cornea has equal power in central and periphery, then it would be quite a large amount of hyperopia that you should expect at that level. But you don't, because in the periphery, cornea also starts flattening out. So probably they are sort of compensating for each other. So that could be one of the possibilities. And regarding the question whether it should be measured in all the patients, see, as I always say that, we all at this point of time, whatever we are doing, we are trying to accumulate data. We are trying to understand myopia. and there will be lot of treatment protocols which will change over a period of next 10 years, where we would be thinking that, oh, I thought this was working, and we may change our protocol and believe that it was not this which was working, and actually it was this. So for example, I will give you an example. For example, if you see, vitamin D suddenly became a very important point in myopia control, and later they realized that, oh, my vitamin D was not the actual point. It was actually not sitting outdoors, and since not sitting outdoors itself is a risk factor, and so those patients who are not sitting outdoors were more prone towards myopia or myopic progression, and vitamin D was just a sort of a marker which was trying to mimic the amount of time they were spending outdoors. So giving vitamin D may not actually lead to good myopia control. And so why do we give vitamin D in our practices? Mainly because to make sure that these particular patients should not have vitamin D deficiency, and not that we expect that vitamin D is actually going to control myopia. So it is like omega 3 fatty acid. When something new comes, all the diseases, everybody feels that, oh, omega 3 is very good, and omega 3, and then gradually over a period of time you realize that, oh, this was mainly because all the vitamins were low. Like vitamin D is also implicated in dry eye, and recently I was talking with these Entot Pharma people. They have come up with OcuBiome. They have come up with probiotics for dry eye, and recently, there is a publication from Dr. Rohit Shetty and Dr. Shruti on low-grade inflammatory markers seen in patients who have myopia. So now, if then it is very similar to dry eye, which also has low-grade markers. I mean, the paper is not just on that, but I'm just trying to draw parallels where I'm trying to say that maybe in future you may see that OcuBiome may start giving it for myopia also. So these are things which are evolving, and with time, I think we will have more clarity. At this point of time, honestly speaking, you really don't have to do peripheral refraction for all the patients. But if you do peripheral refraction for most of your patients, it would become very easy for you to know that this much amount of peripheral refraction is useful and this much is not useful, and you can formulate your guidelines before you start following somebody else's guideline. So at this point of time, we are not pretty sure how much peripheral we have to measure. And the paper which I was talking about says that the sweet spot of retina is 9 to 10 degrees in periphery. And if it is 9 to 10 degrees in the periphery, the peripheral defocus lenses, they actually start acting at 20 to 25 degrees periphery, because the central 25 degrees they are supposed to leave. So if it is in 9 to 10 degrees, the sweet spot is at 9 to 10 degrees, then it would be very difficult to treat with these glasses, because these glasses are actually treating much more peripheral. So maybe they are doing the right thing or the wrong thing. We will find out over a period of time. The answer was very long, right? I don't know whether it gave answer to the question or not.
Yes, yes. I have one another question. Uh,
Yes.
uh, See, if we get number one is, how do you convince your patients for these myopic glasses? That is a practical question. Number one. Number two, if the because these, and second question is, these glasses cover up to -9 or -10 diopter only. So if you get
Yes.
a patient directly who is having more than that myopia, then
Hmm.
means what treatment do you start? You start with, let's say, low concentration atropine, and if it is not sufficient, then how would you proceed?
See, I think see, my answers will be very practical. So I'm not talking about data-driven things, or not trying to prove that if I want to do something, I can do that. See, there are people, and I have been to multiple meetings where they do discuss that, and I'm telling you honestly that people have done that also. I don't know to what extent, but see, Nitin, if your power is more than 10, so the Stellest and those glasses come up to 12 now, the extended versions. Okay. Now, if your power is suppose 12,
Okay.
I think this falls mainly into pathological myopia. I don't think anything above 9 or 10 would be very easy to treat. Now, how they are treating, I will tell you. I think in Rajkot, I had a patient, Pooja was also treating, and I met Yashwant Saoji also, and he told me that he has also treated couple of patients. So what they are doing is, so there are two, three approaches. I forgot the first question, but I will first answer the second question. So the second question was that what happens if you have a larger number and you don't have the glass power to match that particular thing? So what they have done is option number one, they use soft contact lenses for like if it is minus 12, they will use a soft contact lens for minus 10, and rest of the power they will give in glasses. Minus 2, they will make a peripheral defocus lens of minus 2, and they will tell the patient to use contact lens and also use glasses. That is number one. Number two, Dr. Yashwant met me and he said that, you know what you can do is you can use a ortho lens, and with the ortho lens, you can cut down the power by at least 6 diopters, and the rest of it you can take with glasses. Then number three is that you can these are two things. Third thing they said that you can use a MySight lens, which is a soft contact lens, and you can cut down the power and whatever is remaining. So MySight lenses are themselves good enough for myopia. So you can use a on the top of it if you want to use some glass, you can use a plano lens. So this was some of the strategies. For me, I don't go, I'm not, I don't go this much, I don't take so much amount of risk for a 9-year-old. I will not tell him to wear a contact lens and then wear a myopia control glasses. I tell them that, you are already at the level of 12 diopters, which is huge. Already 12 diopters is pretty huge. I don't think that much will change or we will be able to do because uh, it is very difficult to do peripheral refraction also in these patients. It is very difficult to do refraction itself in these patients. Most of these patients, if you see, you will see that they don't progress much. All this progression occurs before 6 or 8 years of age, and then they don't progress much. Yes, I have used, so I use high concentration atropine in these. We use 0.05% Myatro XL, but otherwise we don't try to go much into this because I think this is close to pathological myopia or extremely high myopia. And all these treatment protocols that have been argued, discussed, are mainly for school going myopia. But if you want to do something, you can use a contact lens or a ortho K to reduce or cut down their power and then fit them into myopia control lenses. So that is, that is the answer to part two of your question. What was the part one? I forgot.
Practical. How do you practically
Okay, how do
convince
we
your
convince the patient? Okay, so basically what you do is it will start when the patient comes to you for in the first visit. So when the patient has come to you in the first visit, you are not planning to start anything, but you definitely talk with them. Like if you're seeing a ROP baby, you talk about the fact that if it worsens, you may have to do laser. Like if you talk about an intermittent exobation who has good control, and you tell them that if this worsens, we may have to do a surgery. So you tell them firsthand itself that this is myopia, this may progress, and bulk of these myopic patients will have parental myopia or family myopia. And the good thing about myopia is that most of the family knows that this minus number increases. So if they know it increases, you reinforce that this number can increase. And then when he comes back after 6 months, you tell him that, see, your power has increased. And since your power has increased, and so we have to do something about it. So there are two options. One is drops and one is glasses. Now, if you want to use drops, you can use drops. Drops are comparable to glasses. The only problem of drops is that you have to use them daily, once a day or twice a day for at least 2 to 4 years. So if you are ready to do that, you can start drops. There is nothing wrong in that. The second point is that, if they are convinced for drops, they will come back. If they are controlled, wonderful. If they are not controlled, you can tell them that, we have to add on something else also, because your power is still increasing.
Okay.
See, just now only we received this ortho lens. This has come today only. This is, yeah, this is how it comes. If you see,
And search
is the
and launch
yeah,
terminal.
so this is the ortho lens. I don't know whether you can, yeah. And it comes in such case. This is an ortho lens from these people,
Dash.
Essilor. I think I can show you in this video. Yeah. So this is a yeah. So this is the ortho lens, and it comes in such a pack, and it has got its refraction. So you can actually see that this is the refraction of the patient, and then it has this lenses there, and these are cases. So if the patient, so this is the patient who is son of a doctor, and once he was wearing glasses and his power gradually slowed down, non-progressive. They wanted to. He was he was into a lot of sports. So this is the case. Max. I don't know whether you can see it or not. And so initially he was, I mean, for orthogonal lenses also, the kid is 8 years old, and initially he was not convinced. But then one of his friend is wearing orthogonal lens, and he's doing well. So then they also got convinced. He's a football player, so he wanted to make sure, and his power has not increased. He's on, I think he's on DIMS since last 3 4 years, 3 years. Father is a father is a myop, mother is a myop. Both the parents are myop. Single son. So you have to start when they come to you for the first time. You can start from there. Yes, Dr. Snehal.
Uh, 1 minute. I don't know whether you can you hear me?
Yeah, yeah.
Actually, I was a little bit distracted. Um, Actually, my real problem is that I am in a medical college, so my
Hmm.
patients are really not very. Means I want to do so many things, but they are not regular in follow up, and so my work is not as much as I would like it to be. This, so I
No,
was.
but actually, madam, see, if you are in a government medical college, no, it is much easier for the patients to convince them. I will tell you how. See,
Uh-huh.
to the doctor, the glasses are available at 9,000 rupees.
Sorry.
To the doctor, to us,
Mhm.
these Silor glasses are available at 9,000 rupees.
Okay.
So you can always, you can very easily give. So bulk of our patients, what we do is that, if number is a problem, and if we are not, see, we are all scientific people. It is unimportant for us that, whether we earn a huge amount of money from this or not. No, it
Correct.
may be a problem for some of us, but at least personally for me, I don't think it is much of a problem. So what I do is I would try to give them at a very low cost, so that at least they are using those glasses.
Okay.
Once they are using those glasses, then it becomes very easy for me to convince them and to find out the data. See, you can easily find out whether this particular glass is working for them or not if they are using it. if nobody is using it, it is extremely difficult. So we are not into corporate. See, I know there are, so these companies only tell me that, there are corporate hospitals where they are prescribing more than 20 glasses every month, which is a very big number. And we
Yes,
see a lot of myopes.
yes. So no, what happens is that I'm doing low dose atropine glasses. I have tried, but then when they hear even the 10,000 rupees, they are not very affording.
So,
And low dose atropine, actually, what was happening earlier, recently only we got an IOL master. So now the
okay.
monitoring has become simpler.
Yes.
Earlier with the A scan, some children would allow, some children
Yeah,
would
true.
not
Very
allow.
true. Very true.
So
Very
it was
true.
going totally on the change in the refractive error. So
In
I
fact, you can also use some online myopia calculators. I think Zeiss can, but all these companies know they will be able to help if we are giving them some revenue. I
I
mean,
have tried the BHVI. I think that's free.
BHVA is good, but BHVA is pretty simple. But yes, it is free of cost, so it's a good idea to use BHVA.
Okay. So I think
But
maybe
it's a good idea because what good it does is it gives you nice diagrams, it gives you graphs. You can show it to the patient, and even for ourselves also. We also understand that over a period of time, this is what has happened.
maybe what I can do is give the next thesis with involving the calculator, and
Yes, you can
then
give it.
try.
I was actually finishing one of my articles on comparison of myopia calculators. So you can definitely give comparing a myopia calculator, which calculator would be better. Also, you can give thesis on the changes in choroidal thickness over a period of time. You can give thesis on choroidal thickness with myopia progression and how much choroidal
How,
thickness
how
precedes.
frequently do we need to follow up for this, and for how long do we need to follow up for the
At least for 2 years to have for myopia
effective?
calculator, at least for 2 years to really, to be able to quantify that actually the calculator predicted something and it actually happened. Because the calculator may be able to predict for 6 months or 1 year, but may not be able to predict for a longer time. So we have to, I think what we are coming down to is very similar to the debates that used to happen on IOL power calculations.
Okay,
So there are a lot of calculators available in the market. Um, you can, I mean, it's very easy to talk with these companies and get access.
okay, I will do that. I will try that. Comparison of calculators. Okay, maybe you could,
Myopia predictive calculators,
yeah,
yes.
maybe you could help me connect with one of the companies. I'll.
Yeah. I think we can do that. I think Cooper Vision has their own calculator. Zeiss have their own calculator. Essilor has calculator. Pre-myopia onset, there is a calculator. BHVI obviously has a calculator. LVP has a calculator. Remedio has a calculator
So many.
incorporated in their machine. So no, the point is Marcus Ang is using. I mean, he's fully devoted. He's from where Audrey is there. Singapore National Eye Institute. So he's talking about a lot of AI in this myopia because at the end of the day, there are two most important questions. One important question is who will progress, and it's like glaucoma. So, when the patient comes to you on the first visit, you are wasting out 6 months. So, whether you can start the treatment at beforehand only, so that is there. And second thing is that what would be the progression curve? Because a lot of patients, they stop progressing for a couple of years, and then suddenly there is a pubertal growth spurt, and they again start progressing. So there are a lot of lot of division when it comes to growth spurts of eyeball. It's not linear. It doesn't keep on progressing once the kid is around 14 or 15. Some of the kids may still progress, and some of the kids simply just stop after 14 itself. So, and that is one of the some of the times we are asked the question that why the studies are between 4 to 15 years, because they want patients who are actually progressing. They don't want that confounding variable that the reviewer can say that, oh, after 15 years to वैसे ही बंद हो जाता है progression. So, फिर what was the point of maybe some of your patients actually did not progress because they would not have even progressed
That age
otherwise.
group.
Yeah.
I don't know because the total thesis period, including submission, is 2 years. So I may be able to follow up only for 1 year or 15 months
But
of.
still, but still, you can give. I mean, 1.5 years is a good amount of time to know.
Okay. Let me see. Then maybe that will also encourage my myopia work in a more systematic way.
Yeah, yes, yes. Also, you can give thesis on choroidal thickness with comparison choroidal thinning and non-choroidal thinning, like whether it is the choroidal thinning which precedes myopia progression and how much choroidal thinning occurs. What are the factors related with choroidal thinning? Because most of us are now shifting towards choroidal imaging rather than anything else because everybody believes that it is the choroid which holds the key to everything. Maybe as I was talking about other things, maybe after a couple of years we may be talking about something else because I
Yeah.
think there is a molecule 7-methylxanthine which may come up. They are planning to do phase 3 trials. So I think in a couple of years we may have that also, and that
Okay.
I think acts directly on sclera. So
Okay.
maybe we may have more interesting molecules.
Yes. Okay. Thank you. Not much. Not more at present. Let's see. Hopefully, I'll if I have planned this study, I will get in touch with you. Definitely.
Sure, 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 sure.
Yeah. Thank you.
Okay. Dr. Monica, Dr. Chandrakishore, if there are any questions, Dr. Nitin, if yeah, Dr. Chandrakishore has
Hello.
like, yeah,
Good evening, sir.
yeah. Good evening.
Uh, Sir, which myopia predicted calculator you will prefer? You said like
Um,
a lot of
yes.
in market is there, but which you will prefer, sir?
So see, BHVI, BHVI is free of cost. That is number one. So
BH?
bhvi.org. So it is
Okay.
there in the lectures. I can what I can do is I can send you a link in the group, so you can directly go on that.
Sure,
Branholden
sir.
Vision Institute.org, bhvi.org. That is free of cost.
Okay.
Second thing is that now the ocular biometers which are coming, like Hewitts, Remedio, these two companies have their inbuilt calculator. Also, Maya, Topcon also has the inbuilt calculator. Inside
Okay.
the machine itself, they have built a calculator. Then there is a calculator known as pre-MO, pre-myopia onset, pre-mo.com.
Okay, sir.
That one is that there is some free trial available, but that one is paid also. But what you can do is you don't need to go on all this. What you can do is if you are interested, you can tell any of the companies. They will be more than happy to help you out because at the end of the day, they also want their revenue to increase. And once you
Okay.
have the calculator in your place, you can easily convince more patients. So their interest is towards their interest is commercial.
Okay, sir.
So, but BHVI is free of cost. Then Ocumetra is there from Cooper Vision,
Okay.
and then Essilor has, but they don't give access to us. So Essilor is of no use. But there are multiple calculators which are there. I have now I have got Remedio OBM12, so it has got its own inbuilt myopia progression calculator.
Okay. And one more thing, sir. I am planning to set up my one. I am planning to set up my whole clinic, new clinic. So, which basic instruments you will prefer for myopia control progression? Basic instruments.
I don't think you need anything except making a format. I mean, most of the ocular instruments you have, maybe you have a biometer, right?
Okay, I have to purchase at right now. I didn't have, so
Okay.
that's why I said which basic instrument you will prefer to buy.
You don't need anything extra. I mean, whatever your ophthalmology practice has, you don't need any extra instrument.
Oh,
If you want to buy, you can get a OBM 12 because it will cover everything. Like it will cover auto ref, auto K, ACD, white to white, and this thing,
oh,
uh, axial length.
excellent.
But you don't need to change your decision based on this. If you already have a ocular, I mean, if you have planned to buy a IL Master 700 or something else, whatever you have planned to buy, you can take axial length with that. I mean, you don't need to buy a OBM 12 because it has got something extra. It has not got
There is
anything extra. In
there
fact,
is
it
no
is
need
not a.
to on IOL Master 700 also you can calculate that
Yes,
Excel link.
of course. Yes, of course you can. There's no doubt about it. In fact, if you are planning to buy that, what you can tell Zeiss people is that they should share their myopia calculator with you. So if you are
Oh,
buying such a higher end equipment from them, they will be more than happy to share their myopia calculator. It is their own software. They can easily, they can be more than happy in sharing that with you.
okay.
Wonderful. So, hello. Yes. Yes, tell me. Any question for me? Yes, Dr.
आपण
Mani.
जो नंबर डायल केला आहे तो इनव्हॅलिड आहे.
Hello, sir.
Yes, ma'am.
I have a small doubt. Like
Yes.
in the near future, I've been treating siblings actually. One progresses very faster, and the other doesn't progress as well.
डायल केला
They
आहे
do
तो
have some
इनव्हॅलिड
amount
आहे.
of they do have some amount of lifestyle differences. Like one is more athletic and the other is not. But it is becoming very difficult to convince the patients why one kid is progressing and the other isn't. That is, I have faced such situations. So
I think we should actually see the simple strategy is to sit and talk with the patient. You have to convince them that this has nothing to do with the treatment protocol. Basically, myopia is indeed a lifestyle. So if
okay.
somebody is more athletic, it would obviously reflect into their myopia progression also. Because all of us, one thing is pretty sure that it is a lifestyle induced
Yes.
disease. So the progression is also completely based on the lifestyle, and progression is the bulk, the major factors are near
Yes.
work, and second
Yes.
is outdoor timing. These are the most important ones. All the other factors have not been, really thought about to be very important. But yes, these two factors have been thought that, these are really important ones. So if we can talk with them and convince them that, this is what is responsible, then I think they would also get convinced that it has nothing to do with treatment. But one suggestion I would give is that if you know that one of the kid has a more sedentary lifestyle, maybe you can tell that person to escalate the dose of atropine, or you can tell that kid to have more more stronger atropine, or straight away on combination
Yes.
therapy if you feel that that particular patient is not responding to treatment.
Okay. Sir, like actually, we have been prescribing MyoCare or SLR glasses. As of now, the response is good. It's just been a year. But when do I need to start low dose atropine also? If I feel the progression, like more than 0.5 diopter
More than 0.5 diopters per
per
year.
year, we need to start on low dose atropine.
Yes. Yes.
Okay. Okay, sir.
If you feel that it is still progressing, you can make it twice a day also.
Okay.
And
Okay, sir.
also, I have seen that children who are on these halt lenses by SLR,
Yes.
they can easily be convinced for ortho-K once they grow up. No need to convince them on ortho-K if they are not progressing. The question is If they are progressing, only then we think of something else.
Yes.
If they are wearing
Yes.
glasses and if the winning combination is moving forward, there's no need for us to become any wiser. I mean, they are already not progressing, so there is no need. But these patients have understood the importance of myopia control glasses. Their progression was halted at some point of time. Atropine worked for them, or glasses worked for them. So it is much easier to convince these patients that ortho K is also a good option.
Okay. Okay, sir. Thank you.
Yeah. So I think if there are any more questions, if they're there, we can take. Or otherwise, this would be almost the last lecture, and we will issue the certificates shortly. I will send you the soft copy, and if there are any other things, you can always send. You can always WhatsApp. But it was really good, and uh, if there are any further updates, I was actually planning to write on myopia calculators. I was telling Max also that we can make a video and post that video also, because that will also become one of the important things. If there is anything new which comes up, we would definitely be try to make some more presentations for that also. And if there is anything else you require from us, do let us know on the group. So thank you so much. If there is anything, if there's any other help, or if you want to see any lectures, we can add you into that.